Our next speaker is Dr. SWAPNA Nair, a senior consultant cataract and refractive services at the Chaitanya Group of Hospitals, a very prominent cataract and refractive surgeon of our country. And she is going to talk on something very important for all of us, material and design behind PHAKIC AIOS. And on to you, SWAPNA. Nice seeing you.
Yeah, ma'am. So that is a recording I made of the presentation. Because I mean, my camera was giving me a lot of trouble. So I'd like to play the recording because I'm not sure that I'll be able to, keep the camera on, or I may just fudge it up.
Go ahead. Go ahead. You be with us for the discussions. Yeah. Can you open your presentation?
Yeah. Yes, ma'am. Yes, ma'am. Talking about Star Vision ICLs. So we know that the basic requirements of PHAKIC intraocular lens is that it should be biocompatible to stay inside the eye, should be able to pass through a very small incision, sub 3 millimeters. It should be soft and pliable for non-traumatic maneuvering, both into the posterior chamber and out of it if required. It should be very thin so that when it occupies the posterior chamber, it causes no deformation of the iris or no trauma to the lens beneath it. It should incorporate a wide refractive range, especially because a lot of patients that come in for a implantation of a PHAKIC IOL are patients that are unable to do a laser refractive correction of the cornea, and they may have a higher range of power than is proposed for LASIK. And of course, it should be non-brittle, easily deformable, so that can be easily extracted. The lens is made of a combination of hydroxyethyl methacrylate, which is 99% of the material, and 1% collagen. Now, this combination makes sure that it is quiet inside the eye. At the same time, it has a very good transmittance of light and a low reflectance pattern. It's very flexible, so that whatever we wanted earlier, like passing through a small incision or the ease of injectability into the anterior chamber or of removal becomes very smooth. And of course, it's easy to incorporate all the range of refractive powers that we want into the lens by lasing. So we are talking about a combination of polymer of human collagen-like material and porcine collagen-like material and a hydrophilic acrylic material. Now, this extreme pliability makes sure that whenever the lens is passing through very narrow tubes that it requires for loading, or when it's being pushed out for injection through a small incision, it remains unbroken and can easily get back to its normal shape, the shape that's supposed to sit inside the eye, even though it gets deformed heavily inside the tube. And even for explantation, when it's brought from the posterior chamber into the anterior chamber, you can see that it does not damage any of the tissues involved, and by itself also does not get damaged when being pulled out through the same incision that it was passed into, unlike an intraocular lens, which sometimes needs to be cut before being removed. Now, why is it quiet in the posterior chamber? It's basically because of the property of this material that we've talked about, the Collamer, which minimizes inflammation, flare, and any sort of cellular reaction inside the anterior chamber. And so it's ideal even for patients who are prone to inflammation like diabetics or those that have chronic uveitis, though we only insert the lens when the eye is quiet. There is a formation of monolayer of fibronectin around the lens, which prevents any sort of reaction with the all the materials in the aqueous humor. So because of that reason, even in this eye, which is a post-trauma cataract extracted with an IOL placed inside eye, you can see the amount of inflammation that's there and all the posterior synechiae that are there. Even in such an eye, when there is a large refractive error, you can easily put this lens as a piggyback lens, and this allows for the correction of the lens of the refractive error. It also makes sure that it does not cause this inflammation-prone iris to get more inflamed. It does not deform the iris further. So this because lens can sit on top of the intraocular lens and prevent any sort of biofilm formation between the two interfaces. So all this ensures an extra indication for that lens. So we know the positioning of the lens is behind the iris, unlike a lot of initial phakic intraocular lenses that were either placed in the anterior chamber or clipped to the iris. This ensures that far from the endothelium, there's excellent cosmetics invisible to the naked eye. And it's definitely close to the nodal points of the eyes, increasing the retinal image size. And so
we can hear you now. We can hear you.
At the corneal plane, but that varies depending on the dioptric power of the lens.
I want to know whether
because it's placed in the sulcus, it's a stable position. You can have a toric design on the same platform. It does not. It is not prone to rotation. It's easy to remove and exchange because it's not too deep within the eye, and there's no fixation to iris tissues because of the white nature of the lens. It does not alter shape. There is no removal of tissue from the cornea, unlike in laser vision correction. Now it has a plate haptic design with 4-foot plates and a forward vault, which is incorporated into the design of the lens. There is also provisions for aqueous drainage so that you don't need to make any more peripheral iodotomies. There's a hole in the middle of the optic for improved aqueous humor flow. Now the basic hardcore specs of this lens are the optic diameter of a variable range depending on whether you're using it for myopic correction or hyperopic correction, and that varies depending on the power that needs to be corrected. The power correctable range also varies all the way from -0.25 to -18 for myopia, a lesser range up to 10 diopters for hypermetropia, and a range of around 6 diopters for astigmatism. Again, the sizing of the lens also has a good variance from 11.6 to 13.7 millimeters, depending on what type of error is being corrected. So you can see all these in this diagram. Now, the natural vaulting of the lens that is incorporated in this lens makes sure that it stays away from the anterior lens capsule without deforming the iris too much, so that this lack of contact with the anterior lens capsule ensures that there's no, it's not prone to cataract formation. And in such a situation, the ideal lens mode that we're looking for is somewhere between 200 to 800 microns. You can have high or low walls, but that depends on the lens sizing and not on this natural vault of the lens. So if you have an inappropriately high-sized lens, then you will have a very high vault, making the patient prone to a narrow angle and glaucoma. And if it is very low, then you can have cataract. A low lens is also a very unstable lens, prone to rotation, which is not an ideal situation for a toric intraocular lens. So you can here see how a low vaulting lens is lying loosely in the posterior chamber and can be easily moved by the cannula without actually taking it out of the sulcus and repositioning it. So what we looked up before, the biocompatibility and the ability to pass through very small incision, the pliability of the lens, the softness of the lens, so that it can be maneuvered multiple times into various positions, and the thinness of the lens, which is thin enough to occupy the posterior chamber. At the same time, it incorporates a wide amount of refractive power, a wide range of refractive power. So all these factors combine and form an ideal phakic intraocular lens, both in terms of material as well as design.
Stays for a long time without
Thank you very
inciting
much.
any form of reaction. Thank you very much.
Thanks, Swapna. That was a good talk. It was nice hearing you also. Now, I have a question. Of course, I'll ask Ramurthy, but all of you can put in your thoughts. We'll keep a watch on the time, of course. Do you see any advantage of having a collamer over the present day hydrophilic lenses, which are doing well in the market? Anyway, we also need to know that a collamer component is only, collagen component is only 0.2%. So what are your thoughts against sticking on to ICL or looking at the other market scenario? Dr. Ramurthy, are you there? It's not there. Dr. Partha? Dr.
Yes.
Purendra? Yes,
Yes,
Partha.
yeah. So actually, I use 90% of the ICL only, and because it has been very, very time tested for me and for everybody else. So I have been sticking on to ICL for 90% of my cases. Only 10% I do IPCL.
And Dr. Yes, Kamal?
I think excellent presentation. My only query would be, even with my ICL or IPCLs, I refrain from chronic uveitis. I have seen patients with chronic uveitis who are well settled, and I've seen them have hiccups. They do have intense flare-ups at times. And the other eye where I've not done the surgery, let's say there was a patient who was anisometropic and both eyes were chronic uveitis, they're well settled. I operate one eye and suddenly this eye starts showing up some signs of inflammation. I need to keep them on NSAIDs. So my tick box for chronic uveitis is not ticked either with ICL or IPCL. Maybe this is one area in phakic IOS where you may call me a bit reserved. I'm very aggressive with my phakic lenses, but in my bucket, I do not touch chronic uveitis. I've burned my hand with 4 cases.
So if anybody is for the hydrophilic material, you can raise your different.
I think results are both for results and outcome. Actually, I started doing Indian hydrophilic acrylic lenses from Care Group, and I slowly entered into it, and I followed them. Now for last, I think 3-4 years, I have followed them, and more than that. And I find that results with are comparable with the Collamer ICL lenses.
Absolutely, I agree with
you. There is no much difference because the question is very specific. So I will answer.
Yes.
Cut difference between the two, and the outcome is almost the same, and indications and all are the same.
Okay.
Dr. Chitra, I would say that this material is as good. And I think I would vouch for it. I've done nearly 3,000 of these Indian lenses. Track record of follow-up for more than 7 years now. I've done very, very decent numbers of ICLs. I've also done other Indian brands. So I don't think there's much difference. And you're right, you're just a decimal point of a Collamer. I don't know in real world how much difference it's making, but at least in the clinical practice, I agree with Dr. Purinder. I don't see much difference.
Now, what about using these lenses which have the 180-degree advantage? Now, we do know that we measure the horizontal white to white, and we know that the vertical white to white is less. So now, keeping that in mind, now these Care Group lenses come with a 180-degree advantage, and the ICL come with the different axis measurements. So what is your take on this? Yes, Dr. Kamal?
I think this has a huge advantage even for a beginner surgeon, and even for an accomplished surgeon. It has a huge advantage. It takes the load off, because let's understand, even a 5-degree underwalt is going to give me 15 degrees of undercorrection. And when you're correcting -8 diopters of cylinder, 7 diopter cylinder, 10, 14 diopters of astigmatism in repaired corneas, that faith of landing on 180 time and again, and not depending on rotation and secondary markings and all that, at least in my setup, I am a lot more reassured, and the results are phenomenal. So I think I am more comfortable in this segment with the Care Group lens, when especially I'm dealing with very high astigmatism because of a very, very high predictability.
Dr. Rajesh, would you have something to add on this? Or your experiences with ICL only?
Yeah, my experience with ICL. I don't do the kind of volumes what others do, and I definitely don't have that experience. But whatever I have done over the last 15 years with ICL, I've had very good outcomes without any complications.
Dr. Sanjay,
I would like to make a comment here, ma'am, if I can.
Yes.
There was a study in the IJO in 2019 that said that for every three every one ICL that develops a cataract, 3 IPCLs do. So it was there. So I don't know how much it's true, because even my experience is only with ICLs. So I had just come across it. So does it have anything to do with the material, or anyone with experience, if they would comment on it?
No, I wouldn't agree at all. If the parameters are followed, the sizing is done
Absolutely.
appropriately, there is absolutely,
Preoperative.
we've not had a single situation. These are, the issue is about the measurement, which is the
Yes.
challenge. And if that is done appropriately, all materials are really
I
good.
completely agree that
Yes.
some of the IPCL with cataract that I have managed in my practice have been purely the undersized ones.
Absolutely.
It's rotating, and the primary surgeon has not gone back and exchanged the lens. And because of the undervaulting and the movement, the patient has developed cataract, and then we had to remove that and do the cataract surgery. But if you recognize, see, the problem is, the advantage of ICL is that you have 0.5 steps. So even that little bit of variation of white to white measurement, that 0.5 step kind of takes care of that. Whether you get a little bit of excessive vaulting, but with the IPCL being in 0.25 steps, you have to be extra careful about the white to white measurement, because it is not as forgiving as the ICL. So you will have sizing issues more with the IPCL than with the ICL.
Anaga, you have a question? I have one, but if you have, you can take yours. Anaga, are you there? Okay, this is something very basic, I think, which will be of
Yes,
use.
ma'am.
Yes, Anaga, you have a question to ask, or shall I take mine?
No, you can go ahead, ma'am. You can go ahead.
No.
There was some connectivity issue, that's why there was a problem.
No, I just wanted to ask you all to clarify. I'm sure we all know the answer. Why is it that all phakic IOLs are plate haptic lenses, which are kept in the sulcus, as against the sulcoflex lenses, which are have an optic and a looped haptic design? What could be the reason? Have you all? Can you all? Any of you throw light?
The Sulcoflex is meant to be put in a pseudophakic eye.
Yes.
The design is such, so it doesn't take into account the anterior curvature of the lens.
Yes.
Whereas the ICL is designed to take care of the anterior curvature of the lens, so it has to have in plate haptic, so it can sit in the sulcus and the rest of the lens rises over the crystalline lens.